Paramedics are here.
Medic 54 to County Priority 1.
Ma'am, I'll go ahead and take over.
Ma'am, tell us what happened.
She was outside playing out in the backyard with the dog. And I came inside because the phone rang and the dog was barking. And when I looked back at it, I couldn't see her. The full cover was up.
She's both with apnea. I started CPR.
Okay. We're going to take good care of her, okay?
Please tell me my baby's going to be okay.
When the tones drop and the dispatcher says child not breathing, even the most experienced and jaded paramedic's pulse will quicken just a little bit. Surveys of EMS providers consistently rank pediatric emergencies as among the most stressful psychologically and emotionally of any call that they run. And when it comes to pediatric arrest, the stakes couldn't be any higher. Add in the emotional distress of the caregiver and the unique pediatric sizing and dosing concerns, and it's no wonder that pediatric arrest induces more pucker factor in providers than just about any other type of call. But pediatric resuscitation need not be overtly stressful, chaotic, or rushed. In fact, many of the skills and techniques that we employ for adult cardiac arrest are equally applicable to even the smallest of our patients. That's what we're going to talk about on this episode of Medic Monthly. Pediatric patients make up 27% of all ED visits, and around 7% of those arrive by ambulance. Roughly 13% of EMS calls involve kids, and even fewer than that involve cardiac arrest. Bottom line, we just don't run enough pediatric cardiac arrest to feel proficient, but that doesn't mean we can't be proficient. When it comes to pediatric emergency care, we're fond of saying children are not just little adults, to illustrate the importance of appropriate equipment sizing and medication dosing, and to emphasize the unique physiologic and anatomic characteristics of pediatric patients. However, that approach has inadvertently hampered our ability to manage a pediatric resuscitation effectively by fostering the perception that we have to utilize a different skill set when it comes to pediatric patients. The reality is, good patient care is good patient care, and there is very little about pediatric resuscitation that should be foreign to most EMS providers. Every resuscitation is unique, yes, and we typically have to adapt our methods and our treatment to fit the patient's clinical presentation. But pediatric patients simply represent just one more adaptation of long-practiced techniques and skills we already possess. Kids don't usually go into cardiac arrest for the same reasons as adults, that's true, but some kids do, and recognizing them is an important part of your resuscitation-oriented history and initial assessment. Even so, pediatric resuscitation isn't so much a different skill set as it is simply a shift in priorities and sequence of the things we already know how to do.
All right, guys, welcome to our training session for today. This is going to last about, maybe about an hour and a half. Here's our objectives. We're going to review our engineered CPR protocol, look at our cardiac arrest SOG, specifically our pediatric dosages and so forth. Best practices for pediatric medication dosing. We're going to talk about cognitive offloading, using things like Broslow tapes, phone apps, etc., to help us with our drug dosaging. And we're going to talk about family relations as it relates to pediatric cardiac arrests. And we'll have a kind of a group test here as part of this PowerPoint. And then after that, we'll do some hands-on practice. This is a video that's going to just keep playing from start to finish. There might be some times in here where I ask you to pause it and have some discussions, or I'll just give you about 5 minutes of dead time where you can talk about whatever you need to talk about, and then the video will continue to play. So let's move on here. First of all, we're going to get into our engineered CPR, or our pit crew protocol. First of all, let's look at the positions of the pit crew CPR. This is designed for 6 providers minimum. So in our system, what that looks like is 2 people showing up on an engine, 2 on a medic unit, and perhaps an additional 2 on a second engine. And then a chief officer will likely respond also, especially if it's during daytime hours. So what are those 6 providers doing? As we know, chest compressions is king. So listed there at the very top, we've got 2 providers that are going to rotate providing chest compressions. And along with that, early on, the application of the defibrillator pads, or the AED. So within this, we've been calling it a BLS triangle, 2 on the chest and then 1 provider managing the airway. So early on, putting in that OPA and applying the non-rebreather mask or the bag valve mask, depending on the call, and then the end-tidal CO2 monitor. So that's the BLS triangle. We also have 1 provider that's monitoring CPR quality and has that eCPR checklist in their hands. And we'll talk more about that checklist here as we go. And then we've got a provider that's working on IV medications as well as a float position. And as we know, this all depends on the call, how many people we have, and so forth. Continuing on with that pit crew CPR or eCPR protocol, just as a reminder, what does really, really good chest compressions look like? And since I'm not right there in front of you to demonstrate, here's the criteria. So the rate is 100 to 120, and we have metronomes built in to our EKG monitors to help us maintain that rate. And there's that magic 10 seconds. We don't want any pauses greater than 10 seconds. And when we practice this, and I see guys doing it running code blues, it's usually more like 4 or 5 second pauses, which is awesome. That's what we want. Deep and hard, so compression at least 2 inches, and then as you see there, 1.5 inches for infants. Which again, we've got some feedback mechanisms in place on our Zoll monitors that help us keep within those parameters. We're pushing too deep, or we're not pushing deep enough. It helps us to know. And I think we've had some issues with that in the past, especially with infants, as to how well that works. We're not leaning on the chest. We're allowing for full recoil. Every time we push down, our hands don't come off the chest, but we make sure our hands come up all the way to allow those chest heart chambers to completely fill. After every 220 compressions, or about 2 minutes, we're going to rotate, analyze and shock as indicated, and then provide airway management as needed. And we'll flush all this out a little better as we go here, and establish an advanced airway IV, and then of course deliver our medications as appropriate.
Okay, Jen, the EasyIO is in. Epi is going to be 2.7 milliliters. We need to keep an eye on the clock. We need to switch compressors every 2 minutes on the even numbers. Medication will be on the odd numbers.
We got 1 more minute till we switch compressors.
Great. I'll come up and switch after that. Okay, in 15 seconds, we're going to charge the defibrillator. Ma'am, my name is Greg, okay, and this is Jen. We're going to do everything we can for her, okay? We're going to do everything here just like they would do in the emergency room. Her best chance of survival is working her here, okay?
Okay.
Greg, we're at 15 seconds.
Great. Charging. Okay, I'm clear, you're clear, we're all clear. Shocking.
I like the way these medics work. It's obvious they've done this before and that they've rehearsed their moves extensively. But did anyone notice that the medic automatically knew the patient's epinephrine dose and defibrillation joule setting, even though it's weight-based? The answer is they're cheating. And if you're not cheating at pediatric resuscitation, you're not trying hard enough. In Dr. Atul Gawande's checklist manifesto, he relates the story of an unflyable airplane. A number of test flight crashes of the Boeing bomber prototype occurred, and there were numerous injuries and deaths. The plane was deemed by test pilots as too much airplane for one man to fly, until the pre-flight checklist was conceived. That checklist allowed the plane to be flown nearly 2 million miles in testing without a single incident, and the prototype went on to become the B-17 bomber, playing a vital role in the Allied victory in World War II. Since then, we've recognized the value of reference tools and procedure checklists in performing complex tasks. They're used extensively, not only by airlines, but by other industries as well. And they're even a key component in performing surgical procedures. When it comes to performing complex tasks like pediatric resuscitation, it is far better to stand on the rock of a written reference tool rather than the quicksands of memory. There is no shame in looking things up. Using a pediatric dosing guide, resuscitation checklist, or sizing chart allows for what's called cognitive offloading, allowing us to focus our decision-making processes on more important things. Unlike adult resuscitation, where medication doses and equipment sizes are relatively uniform and easily memorized, pediatric resuscitation relies on weight-based dosing and sizing. Calculating a child's proper medication dose, the proper ET tube size and depth, and the proper energy settings for cardioversion or defibrillation while simultaneously questioning the parents about arrest events, directing the actions of other rescuers, and engaging in resuscitation problem solving is a tall task for any provider. As the saying goes, if you're doing math problems in the middle of a pediatric code, your priorities are in the wrong place. Hence, pediatric resuscitation guides that do the math for you based upon the child's weight, height, or age are commonly utilized, and the Broslow tape is among the more commonly used tools. Length-based resuscitation tapes give equipment sizes, medication doses, and defibrillation cardioversion settings based upon the average weight of a child of that height or length, since we're typically using them when the child is supine. They are fairly accurate for a child of average weight for his height, but they require you to arrive at the patient's side and measure them before you know what size equipment or dose of medication to use. Age-based resuscitation guides like the hand-TEVI system provide equipment sizing and medication dosing for an average-sized child for that age. Age-based systems do have an advantage over length-based systems in that they allow the crews to pre-plan their actions based upon the age of the child from dispatch information before they arrive on scene. Now, while we won't endorse one product or another here, it's important that you use something and all crew members be familiar with its features. The use of a resuscitation checklist and/or dosing guide and good small group communication are key elements of crew resource management, or CRM, and are the foundation of intricately choreographed resuscitation techniques such as pit crew CPR. You see the medics using similar communication techniques and scene choreography on their patient, and they were able to reference their age-based pediatric resuscitation guide before they even arrived on scene. Use a pediatric resuscitation checklist and refer to it throughout the code. As a matter of fact, it's a good idea to adopt a similar approach for any complex medical task for adults as well.
Now, after watching that video, there's a couple things I'd like to discuss. One is the cardiac arrest checklist. So we're going to take a look at this checklist, and then I'd like to talk to you guys about reference tools. So first of all, the cardiac arrest checklist, where is it located on our trucks? And do we use it? I've been on cardiac arrests where we have used the checklist, and I've been on cardiac arrest where it hasn't been pulled out. Sometimes, I think the last time we trained on this, some guys said, yeah, absolutely, here's where it's located, and others had no idea. So I'd like to revisit the use of this cardiac arrest checklist. So let's look at each little component here. First of all, listed at the very top are compressions, and you'll get sick of me saying it, but compressions are king, and we've got to be doing that part right. So going down the checklist, do we have the metronome on? Are we making sure that we're not having pauses over 10 seconds? Are we counting our compressions? Are we switching compressors every 220? Are we set up so we know who's going to be doing compressions next? What cycle are we on? And why is that important? What's magic that happens after the third cycle, beginning at the fourth cycle? Down to the next section, do we have the patches on? And then there's a place to record defibrillations. Help us keep track of that. And then the ventilation and airway management section. Has an OPA been placed? Are we either on a non-rebreather mask, or are we ventilating at an appropriate rate? Do we have end-tidal monitoring set up? ET tube, supraglottic airway, and whether it's asystole, a PEA, really any code blue. Are we checking blood sugars? Have we gone through our H's and T's to try to figure out if there's something we can do to help get ROSC? And looking at other ALS interventions. So who's holding this checklist? We talk about in some services they call it the code commander, and we've never really dictated this person's going to have the checklist out, but is this beneficial? And I would say absolutely yes. That if we have somebody that's standing back with this checklist, monitoring operations and recording things as they take place, that's going to help a lot. It's going to help with the organization of the call. It's going to help to make sure that nothing is missed. In the video, they talked about crew resource management. I think this cardiac arrest checklist helps a lot with managing our crew resources. I think we've all been on calls on code blues that were very well organized, and we had one or two people calling the ball, and everything was getting covered. Been on other code blues where it wasn't really clear who was running the code, if we were hitting all of our benchmarks, covering all our bases. So cardiac arrest checklist. And second thing I wanted to discuss is reference tools. So what do we have in place right now that we can use as reference tools on a pediatric cardiac arrest? Now, the first thing that comes into my mind is our Broslow tape. Second, we've got phone apps. We've got our medical protocols that we can pull up on our phone app. And what else do we have? We've got a medication, a medication drug formulary that we have access to. Well, where is that? Do we have access to it on a call? And we also have a MacBook. Should have a MacBook on all the trucks that we could use to reference this, all this information. So next thing I'm going to do is I'm going to let this video run for about 5, 6, 7 minutes, and let you guys discuss the following discussion points. First one: talk amongst yourselves about that cardiac arrest checklist and how that could help with crew resource management, help organize the scene so that nobody wonders who's calling the ball and what's coming next. Second thing I want you to talk about is your reference tools. So somebody go get the kits that has the Broslow tape, bring it into where you're watching this video. Everybody else, pull out your phone apps, grab a MacBook, bring a MacBook in for this training. Find the drug formulary in the app, find the cardiac arrest protocol in the app. Look at the pediatric drug doses, and then talk about how you would and could use these apps during a pediatric cardiac arrest. And is it going to be the person holding the cardiac arrest checklist that's looking these things up? Is it going to be the person starting the IV and administering the medications? Let's just take the next 5 or 6 minutes and talk about those things. Well, hopefully you're having some good discussion. I'm going to give you about 2 more minutes. If you haven't already discussed it, I would ask, has anybody been talking about the hand-heavy system or the age-based medication system that they discussed in that last video? Might be something to talk about as well. So again, I'm going to give you about 2 more minutes. If you need more time, when you see the slide advance to the next one, just go ahead and hit pause on the video and continue your discussion. All right, nice job. Hopefully you had some good discussion time there. If you have your phone app out, go ahead and go to the cardiac arrest protocol. If you've got a MacBook in front of you, maybe you can look at these medications as they're discussed. Or if you've got that drug formulary out, you can double check all of these. But what I have in front of you is our cardiac arrest protocol, and let's look at some pediatric dosages. So we see here VFib, pulseless VTAC, pediatric dose for our joule setting, 2 joules per kilogram. Repeat dose, 4 joules per kilogram. So also, if you have the Broslo tape in front of you, look at that, find that information on the Broslo tape as well. So epinephrine dosage, we've got 0.01 milligrams per kilogram, epinephrine 1 to 10. So with a 40 kilogram patient, how many cc's of medication, how many milliliters of medication are we going to give that patient? Let's look at amiodarone. Pediatric dose for amiodarone, 5 milligrams per kilogram. Again, look at your reference guides. See if you can find that information in there. Mag sulfate for polymorphic VTAC, pediatric dose, 5 to 10 milligrams per kilogram. And we're going to dilute that. So what's that look like? How are you going to figure that and administer that? All right, and pretty much the same thing in asystole or PEA, epinephrine dosage, 0.01 milligrams per kilogram.
One, two.
Where do you need
three,
us?
4,
Okay,
5,
Matt, I'm gonna have you
6,
take
7,
over
8,
compressions
9,
opposite of her.
10, 11,
Chris, I'm gonna have you take over
13,
ventilations,
14,
okay?
15. You got 15 seconds, Greg.
Okay, we're gonna charge the monitor.
4,
Take over.
6, 7, 8, 9, 10, 11, 12.
Okay, charging the monitor. We still have VFib on the monitor. I'm clear, we're all clear. Shocking. Back on the chest.
2, 3, 4, 5,
Okay.
6, 7.
Ms. Mitchell, right now what we're doing for Elena is we're doing compressions. We're breathing for her. We're giving her medication, okay? I've shocked her twice now. Okay, I'm gonna give her another medication, and I'm gonna give her another medication after that. We're doing everything we can for her, okay? All right, hang in there. Do you wanna stay in here, or do you wanna go sit in another room?
I'm not leaving her.
You're more than welcome. I want you to see everything we're doing for her, okay? All right,
Thank you.
we're gonna take good care of her.
3, 4, 5.
Greg, we're coming up on an odd minute. We're 30 seconds away from our next medication dose.
Great, thanks. Okay, amiodarone is 2.7 milliliters. I'm gonna deliver that. Chris, are you having any issues bagging or delivering a seal?
No.
Okay, great. We'll intubate her if we need to in just a minute.
All right, Greg, we have the rhythm check in 15 seconds.
Great, same as last time, guys. Jen, you pick up the compressions after that shock. We've delivered 3 shocks. We've given 2 epis, and we're about to give that amiodarone. Any other ideas, suggestions?
Did we check a sugar?
We can do that, and let's consider our H's and T's.
The medic runs a pretty smooth code, but choreography like this doesn't exist in a vacuum. It takes coordination, practice, and great open communication. Techniques like CPR HD and pit crew CPR are examples of choreographed resuscitation techniques. But ultimately, what you choose will depend on your agency's resources and crew configuration. In this case, it looks like the medics agency relies on a 2-man ambulance crew augmented by fire department first responders and law enforcement if necessary. The medics beat the fire department first responders to the scene this time, and they plugged additional resources into open roles in the resuscitation ballet as they arrived. This is really no different than an adult resuscitation in this respect, except that the body everyone is kneeling around is much smaller. A smoothly run code may look different at different agencies, but the core principles are effective communication and everyone understanding their role, and above all else, nothing interferes with high-quality chest compressions. Everything revolves around that. Now that all the roles in the resuscitation team are filled, it frees the lead medic to attend to the other patient on this scene, the mother. Her emotional and psychological needs are very real. And let's face it, cardiac arrest resuscitation, no matter how old the patient or where it is performed, usually fails. The lead medic can question her more intensively about arrest events, downtime, the child's medical history, and so forth, while providing emotional support to her and preparing her for the steps to come. Such information is invaluable in a resuscitation. For example, we've all been taught that pediatric cardiac arrest is usually a culmination in deterioration of respiratory function. Therefore, we always place a greater emphasis on effective oxygenation and ventilation in pediatric resuscitation. However, sudden cardiac death due to ventricular arrhythmia is not an unusual event in children, especially in those with special healthcare needs that were born with congenital cardiac defects. These children need prompt defibrillation and effective CPR, just like an adult, rather than a greater focus on airway and oxygenation like we'd expect in most pediatric arrests. While having the mother stay in the room during the resuscitation may be met with some resistance from many healthcare providers, it really shouldn't be a major issue for us in EMS. After all, how often do we work patients in a sterile room with only the resuscitation team present? More often, we're performing a resuscitation on a living room floor with family members looking on. There is research to indicate that most families want the option to stay with their loved ones during resuscitation, and that witnessing a resuscitation has, at worst, a neutral effect on their mental and emotional health.
So after watching that video, I think the crew resource management bit, they were doing a pretty good job of that. Good communications amongst the crew members, so that was looking pretty good. One thing I'd like for you guys to discuss now is this business about having the family, in particular the mom, in there watching and being an open kind of having some open communication between the crew and mom, and having mom watch that code blue taking place. I mean, what are your thoughts on that? I'd like to maybe take about 5 minutes and let you guys talk about, is that something that you would allow on your code blue scene? Would you have law enforcement ask the family to wait in another room, or would you be willing to leave the family in there? And I could definitely see some benefits to it. If it was one of those codes that went poorly, or we're having a hard time getting it organized or something like that, yeah, I would definitely not want the family in there watching that. But if you would just talk amongst yourselves here for about the next 4 or 5 minutes, and then we'll move on. Okay, it's been a few minutes here. Let's go ahead and move on. Reflecting back on that video, I don't know that I would be putting my hands all over the mom like that. The guy was rubbing her arms, and that's cool and all, but maybe not. I guess at least he wasn't calling her sweetie pie and sugar honey and all that.
Okay, guys, you're doing great. How are we looking on time, Jen?
We have about 30 seconds till our next compressor switch.
Okay, same drill as before. I'm gonna charge up the defibrillator. We'll continue the compressions, and then we'll switch. All right, and I got a jump in end tidal up to 60. So I'm gonna charge it. Okay.
All right, and we'll check a rhythm.
Absolutely, check
a
the
pulse
rhythm.
in 5, 4, 3, 2, 1.
Okay, charging. Check rhythm. Okay, we actually
I
have
feel a pulse.
Great. We have an organized rhythm. I'm gonna dump the shock. Great. We have a ROSC. Great job, guys.
What's ROSC?
Means we got a pulse back.
Medic 54 to county. We have a status post arrest. Chris, is she breathing on her own?
No, not yet.
Okay, great. Go ahead and continue bagging. Jen, go ahead and grab me a full set of vitals.
Okay.
We'll intubate her if we need to. Matt, can you go grab the stretcher? Great. Let's get her out of here.
She's gonna be okay, right?
Okay, so Miss Mitchell, Elena's heart is beating on her own. That's great news. We're not out of the woods yet, okay? She's still not breathing on her own. We're going to insert a breathing tube. It's gonna help her and us. And then we're going to get her to the ER, okay? Like I said, she's not out of the woods yet, but she's doing much better than she was 5 minutes ago, okay?
Thank
All right,
you.
we're gonna take good care of her. All right.
While the majority of cardiac arrests do not have an outcome as positive as this patient's, we can increase that number with good communication, scene choreography, and high-quality CPR, and the use of a pediatric resuscitation checklist. Remember that just like in adults, resuscitation is most effective when we minimize hands-off time and focus on what we know works: uninterrupted chest compressions and timely defibrillation. Ventilations were being performed adequately with BVM, so they deferred intubation until the post-ROSC stabilization phase because they anticipated the child possibly requiring mechanical ventilation in a PICU. There is research to indicate that, at least for pediatric ventilation for short periods, BVM ventilation results in equal outcomes and less complications than endotracheal intubation, and the research demonstrating efficacy of ETI in all types of cardiac arrest is pretty sparse. If you're going to tube your arrest patients, pediatric or adult, learn to do it without interrupting chest compressions. This crew took their time and focused on high-quality intervention, knowing that was the patient's best chance of survival. We've known for some time that ROSC from out-of-hospital adult cardiac arrest usually occurs on the scene by paramedics or not at all. Thus, many EMS systems have adopted policies of working adult arrests on scene until ROSC or termination of resuscitation efforts, because the act of packaging and transport and doing CPR in a moving ambulance directly interferes with the only thing we know works: uninterrupted chest compressions. Yet many of those same agencies still insist on rapid transport of pediatric arrests, despite evidence that longer scene times, like up to half an hour or longer, along with on-scene intraosseous cannulation and fluid administration, is associated with the highest survival rates of pediatric cardiac arrest. Just like adults, there is little that a hospital ED can do for an uncomplicated pediatric medical cardiac arrest that paramedics cannot. And the perceived benefits of ED interventions must be carefully weighed against the risk of interrupting high-quality CPR during packaging and transport. This crew basically did their standard adult resuscitation with slight modifications in technique and priority of interventions. Once they achieved ROSC, they initiated transport to a specialty pediatric hospital in much the same fashion that adult ROSC patients are transported to accredited chest pain centers. They practiced the science of resuscitation with the art of compassion for the child's mom and allowed her to stay throughout the resuscitation. if the parents are not interfering with your ability to perform appropriate interventions, a similar approach should work for you. If you use your pediatric resuscitation checklist, practice good small group communication, and rehearse your scene choreography, there's no reason a pediatric arrest should be any more stressful or disorganized than an adult one. Thanks for watching. Be careful out there, and we'll see you on the next episode of Medic Monthly.
All right, before we move on here, I just wanted to share with you guys where those videos came from. Boundtree University. If you type that into a web browser, Boundtree University, you can sign up for a free account. And then if you go into their course catalog, there's lots of opportunity for free continuing education credits. So you can see here, Acute MI and STEMI, it's a BLS course, 1 hour in length. But that's where this came from. Here's what we just got done watching these videos, managing a pediatric arrest patient. So just wanted you to be aware of that resource that anybody can use. And if you know somebody that's an EMT or a medic that is not in our department, then they need continuing ed credits. It's a pretty good resource. Now we've got a 15-question quiz that we'll just work through together here. Question number 1, of the following, which intervention has the greatest potential benefit in improving outcome in out-of-hospital patient pediatric cardiac arrest? Number 2, you're resuscitating a 5-year-old drowning patient with a presenting rhythm of asystole. You're performing back valve mask ventilations and have established vascular access and administered epinephrine. Your partner urges you to package the patient and begin transport. Your most appropriate response to this request would be Number 3, you are on the scene of an unwitnessed pediatric arrest in which your 8-year-old patient was last seen breathing 20 minutes prior to your arrival. The parent is distraught and not performing chest compressions. Your first action should be Number 4, the purpose of highly choreographed pit crew style resuscitation techniques is to And let's see how you did. Here are the answers to the first 4 questions. And your next 4 questions. You're on scene performing CPR on an apneic and pulseless child when a parent urges you to stop screwing around and take him to the hospital. Your most appropriate reply would be Number 6, you arrive on scene to find a mother performing CPR on her 6-year-old child. She tells you he has been febrile since this morning and began having breathing difficulty immediately before she called 911 and arrested roughly 4 minutes prior to your arrival. As your partner takes over chest compressions, a police officer responding with you, attempts to usher the mother from the room. You should Number 7, in the midst of a resuscitation of an infant discovered apneic and pulseless in his playpen, your partner points out that the mother's sitting on the couch and her hands clenched in her lap, praying and crying softly. He whispers, "Should she be watching this? Which answer best demonstrates an understanding of the medical literature supporting family presence during resuscitation? Number 8, you have performed the resuscitation on a 3-year-old girl in her home and achieved ROSC after 12 minutes of CPR, vascular access, BVM ventilation, and 3 doses of epi. Your patient is still unresponsive and in need of ventilatory support, so you intubate her and ready her for transport. The mother has witnessed the entire resuscitation and, while obviously emotionally upset, has answered all your questions calmly and has not interfered with resuscitation attempts. As you wheel her daughter out the door, she asks if she can ride to the hospital during the 20-minute transport to the community hospital ED. Which answer best demonstrates an understanding of the medical literature supporting family presence during resuscitation? And here are the answers. I'll give you a minute to read through those. Okay, we're getting there. Another 4 questions. You are a medic on an ALS ambulance who responds to a rural home for a special healthcare needs child in respiratory distress. As you enter the home, you find the patient's mother performing CPR on a frail, thin 5-year-old with a tracheostomy and lower extremity contractures. The mother explains that she is a nurse and that her son suffered permanent brain damage from fetal anoxia during childbirth. He was having difficulty breathing earlier, and when she began suctioning his tracheostomy, he suddenly seized and stopped breathing. She insists on remaining in the room and states that she would like to assist with the resuscitation. You have no other additional personnel available to respond to the call. You should Number 10, a babysitter calls 911 for a cardiac arrest of a 3-year-old. She left unattended in a bathtub. She's performing effective chest compressions when you arrive. And as you take over, a police officer ushers the emotionally distraught teenager from the room. You are performing pit crew CPR with 2 fire department EMTs performing chest compressions, your partner performing bag valve mask ventilations, and a second ambulance crew administering medications and running the defibrillator. You hear hysterical yelling outside and the child's mother screaming, "You have to let me in there. That's my baby." Which of the following approaches best balances the mother's need for emotional support with your need for control of a potentially chaotic scene? Number 11, you're dispatched to a pediatric arrest on a 5-year-old electrocution victim. Which reference tool best allows you to pre-plan your resuscitation before you arrive at the patient's side? Number 12, using reference tools such as pediatric resuscitation checklists allows resuscitation team leaders to focus their thought process on resuscitation steps and problem solving rather than memorizing medication doses. This is an example of You guys got this. One more slide. Number 13. The reason pediatric resuscitation reference tools and checklists are essential in pediatric resuscitation is 14. Use of a resuscitation checklist helps assure that. Number 15. Sandra, a paramedic, and Ken, her EMT partner, respond to a cardiac arrest in which dispatch information noted that the patient was 5 years old. Immediately upon arrival at the patient's side and attaching the cardiac multifunction electrodes to find VFib on the monitor, Sandra tells Ken to charge the defibrillator to 40 joules. The tool that allows Sandra to confidently give her order with no hesitation was most likely And now for the moment I've all been waiting for, your hands-on practice. So the company officer or designee will have your code blue scenario. I'd like for you guys to really work on, pull out your cardiac arrest checklist, pull out your reference tools, work on using those, work on good crew resource management while you're working through these scenarios. Realize the simulators we have aren't the best. Just do the best with what you have. You're not going to get the CPR feedback with our simulators, and at least try to run 2 different scenarios per group. That way you can switch up roles at least once. So thanks for the effort you're putting into this, and let's get started.